A very good afternoon to all. Greetings from Bangalore. At the outset, I would like to thank the entire organizing committee of Pediatric Diabetes Update 2020 for giving me this invite, and it's my privilege to talk on this platform today. The title of my talk is Diagnostic Dilemma in Diabetes. So in next 20 minutes, I'll be talking to discuss about distinguishing features between type 1, type 2, and monogenic forms of diabetes disorder complex. And I would like to do this by taking you through a series of case scenarios. And while doing so, we'll try to understand the significance of establishing the correct type of diabetes and appreciate the diagnostic, therapeutic, and prognostic implications of this. To start with, let's see at this slide with different types of diabetes across the age distribution. As you see, the type 1 is the most common in pediatric population and adolescents as well. And majority, almost 3/4 of type 1 diabetes happens during childhood and adolescent. Next common is your type 2, but majority of the cases of type 2 is in adults beyond 40 years of age. But we do see in pediatric population as well, more so during pivotal age group. And the incidence is increasing because of the increased prevalence of obesity and overweight in childhood. Next comes your MODY. Again, this is more commonly seen below 25 to 30 years of age. And with respect to pediatrics, it is more during pubertal and peripubertal age group. So looking at this graph, we see there is overlapping of these three types of different types of diabetes during early and late adolescent age. So this is where some of the cases might present with atypical features or overlapping features and can pose diagnostic challenges in our management. So before I go to the case scenarios, I would like to brush you through the common or usual clinical features and biochemical parameters which we use to differentiate between type 1, type 2, and MODY. To start with the age of onset, so in type 1, classically, majority of type 1s, more than 75% are diagnosed before 18 years of age, whereas in type 2 and MODY, it is around peripubertal and pubertal age group. Acanthosis nigricans, which is indication of insulin resistance, is classically associated with type 2. High BMI, which is obesity, is again classically associated with type 2, but uncommon in type 1. Beta cell autoantibodies is commonly associated with type 1. C-peptide levels, which indicates the beta cell reserve, is usually low to undetectable in type 1 diabetes, and more so after 2 to 3 years of diagnosis. Whereas in type 2, it is usually supranormal or normal, and in MODY, it is usually lower normal range. Hyperglycemia is classically rapid and severe onset in type 1, whereas in type 2 and MODY, it is usually mild to modest and insidious onset. Ketosis is very commonly seen in type 1, but whereas in type 2, it is uncommon, and MODY, it is usually absent. Family history strongly associated with type 2, and usually the family members are diagnosed with diabetes beyond 40 years of age, whereas in MODY, it is usually multi-generational, at least 2 generations with diabetes who are diagnosed before 35 years of age. Lipids, classically, it is high triglycerides and low HDL in type 2 diabetes, whereas with respect to genetics, it is polygenic in type 1 and is strongly associated with HLA genes. Whereas in type 2, again, is polygenic, whereas MODY is monogenic. So with this knowledge, we'll move to next slide. So traditionally, when we talk about type 1, it means it is insulin deficiency, which is usually seen in lean phenotype, rapid presentation of hyperglycemia, and ketosis or ketoacidosis. Whereas type 2, traditionally we say it is insulin resistance phenotype, and usually seen in obese subjects, slow or insidious presentation of hyperglycemia, and non-ketotic. But in real practice, it is not as white and black as it seems, but we do see type 2 who are lean, type 1 who are obese, and type 2 with ketosis, which is not very common, but it is not entirely absent in this. So again, it becomes a diagnostic dilemma when these things happen. So with this, we can say majority of cases, it is easy to diagnose type 1, but in some situations, there will be overlapping features, and it poses challenges for us. So in those cases, a multifaceted approach is needed, and a single clinical criteria or a single investigation might not be very helpful. And moreover, in type 2 diabetes, as we understand, it's a heterogeneous presentation. There are several subgroups of type 2, such as there are groups which are predominantly insulin resistant with lesser extent of insulin secretory defect, and certain groups are predominantly insulin secretory defect with less extent of insulin resistance. So which we'll see this in next case scenarios. So when this topic was given, I looked at our own data. This is the 7 years data from our institute till recent date. We have around 791 children and adolescents registered with diabetes, and majority around 87% is type 1, and the next common is type 2 with 8.6%. But when we looked at number of cases which had diagnostic dilemma at presentation, which means when they initially presented, at the first meeting, we were not able to ascertain the type of diabetes in these children. So they were around 48, and it formed around 6%. So it's a small proportion of cases, subjects where the diagnostic dilemma will appear. But still, these are the ones which will bother you. So I'll start with my first case, which is very simple, straightforward. A 10-year-old girl born to non-consanguineous couple, severe obesity, prepubertal, severe acanthosis nigricans indicating insulin resistance, high BMI being obese range, and hyperglycemia, high HbA1c, and fasting C-peptide was 10.1 nanogram per ml, again indicating very high levels, whereas GAD antibodies were negative. So any of you have no difficulties in diagnosing this child as type 2 diabetes. So accordingly, we treated her with metformin, and she had a very good therapeutic response. So no doubt this is type 2 diabetes. Moving to a slightly more complex presentation. So it's a 15-year-old girl presented with a very short history of osmotic symptoms, 2 to 3 weeks, and her BMI was in a overweight range. Hyperglycemia was higher levels, and urine ketones were 2+. So short history, 2+ urine ketones, and fasting C-peptide was 2.36, not very high, and it was just above the normal levels, with high HbA1c and triglycerides and HDL, which were normal, and which goes against type 2 diabetes. And anti-GAD antibodies, we are still awaiting the reports. But there was no phenotypic features of insulin resistance, such as acanthosis or skin tags. Mother had gestational diabetes, father had diabetes at age of 45, both grandfathers had diabetes. So there's strong family history of diabetes. And she's a very active person, regularly plays hockey, almost an hour every day. So when we have a mixture of features of some criteria, some favoring type 2, some not favoring type 2. So again, it forms a slight diagnostic dilemma. But in this child, we choose to treat her as type 2 with metformin, and she had a very good glycemic response within 3 weeks. Moving to your next case, 11-year-old girl, normal BMI, very mild acanthosis nigricans, ketones were negative, high HbA1c, stimulated C-peptide 5 nanogram per ml, which is within the normal range, and GAD antibodies negative, but family history of type 2 diabetes. So she responded to metformin. So she is a lean type 2 diabetes. So my point in this child is being lean does not rule out type 2. Because there is a subgroup of type 2 which is called lean type 2, and is more commonly seen in South Asian population because of our increased visceral adiposity, which increases insulin resistance at hepatic, muscle, and adipose tissue. Moving to next is a 14-year-old girl, osmotic symptoms, weight loss, BMI 20 being thin phenotype, mild acanthosis, no family history of diabetes, high HbA1c, severe hyperglycemia, urine ketones were positive, random C-peptide 3.8, again within normal limits, anti-GAD antibodies were negative. So again here, there's certain features which favor type 2, certain are not very typical of type 2, like being thin, ketones positive, low, normal C-peptide. So again, in this child, we choose to treat her with basal bolus, assuming she might be an impending type 1 with progressive loss of C-peptide. So again, is she type 1 or type 2? So what we did was we treated her with insulin. Down the line, 8 months later, requirement was around 0.6 units per kilo per day. But again, when we repeated a random C-peptide, it was 6.3. So it was a bit more reassuring that there was no progressive loss of beta cells. So we treated her, gave her a trial of metformin, and she started responding much better than only on insulin, so which allowed us to wean off for insulin. So again, in this case, the point I want to highlight is sometimes whatever approach you do, you might have to revisit your diagnosis and change your management accordingly, which we did in this case. And next case is a 16-year-old boy, overweight, acanthosis, severe DKA. So he initially presented with severe DKA requiring ventilation, and after a few days he was extubated. Because of the prolonged ventilation, he developed tracheal stenosis and needing dilatation and stent insertion. At presentation, his HbA1c was high, and as per the DKA protocol, he was treated with insulin. Once metabolic and metabolic stability and euglycemia was attained, he was discharged on basal bolus regimen. And following doing the clinic follow-up, we repeated we checked his C-peptide levels and GAD. GAD was negative, C-peptide was 6.9. So it indicated it's very unlikely to be a type 1 because of his good beta cell reserve. So we started on metformin, and within few weeks we were able to completely wean off his insulin levels, and his follow-up HbA1c was in a good therapeutic range. So he is a subgroup of type 2 called ketosis-prone type 2 diabetes, which is more commonly seen in African population and usually in adult population around 3rd to 6th decade. It is otherwise called flatbush diabetes. And with respect to children and adolescents, the literature shows around 17 to 27% of type 2 diabetes in this age group can present as ketosis-prone diabetes. So next is a 19-year-old female presented with hypoglycemia, which was noticed as a routine pre-operative work because she had sustained a fracture of her zygomatis following a fall. So she reports possible osmotic symptoms for 2 months. She had hyperglycemia, HbA1c 7.2, indicating she is diabetic, but her urine ketones were negative. She had normal C-peptide levels, and her autoantibodies were negative. And she was a thin phenotype without any evidence of insulin resistance. Strong family history of diabetes. Both maternal grandmother and mother had diabetes. Mother was diagnosed at the age of 28. She required insulin. She was also dyslipidemic, mild NPDR, possible stroke event, but died before 40 years of age. We don't know anything about other than this. And the child also, the girl also had mild pancreatitis at the age of 6. So the question comes, is she type 1 or is she type 2? Or is she a chronic fibrocalcaneous pancreatic diabetes because of the past history of pancreatitis? So in this case, we approached with basal bolus insulin, and we were able to achieve euglycemia. And first year of diagnosis, she required 0.75 units per kilo per day. 4 months post-diagnosis, we gave a trial of metformin and glimepiride, which she failed. But at the second year of diagnosis, she started having frequent hypos, and insulin requirement came down to 0.35 units per kilo per day. A random C-peptide was 11, indicating there was no progressive loss of beta cells, and HbA1c was 7.4 to 8.4. And other evaluation for hypoglycemia were negative. So we thought she might be more of MODY. So we did a genetic MODY panel, and we found a heterozygous variant in PDX gene, which falls under MODY type 4 classification. And PDX is a gene which encodes for transcription factor, insulin promoter factor, which increases the insulin gene promotion, and it is involved in glycemic responsive insulin secretion. A homozygous form of same gene mutation presents as neonatal diabetes, which is characterized by agenesis of pancreas and exocrine deficiency. A similar variant was also found in a Turkish cohort, and they also found a similar variant in their subject, and they also believe it was pathogenic. In our case, even though it says uncertain significance, that was because it has not been found in the genomic database, and it's got a mild, minor allele frequency. But in silico predictions did show that it was damaging, and we believe this variant was significant in this child. So case 7, 8-year-old male who was diagnosed as diabetes with mild decay at the age of 4. Antibodies were weakly positive. IIA, his fasting C-peptide was low. Thin phenotype, no family history of diabetes. But even after 4 years of diagnosis, this child is only requiring basal insulin as Tresiba, which is less than 0.4 units per kilo per day. And 2 years post-diagnosis, the CGM was near perfect in target range. So very atypical to have such a glycemic curve in type 1. So the suspicion was to look for any other type of diabetes in this child. So when we did a MODY panel, it came as PAX4 heterozygous variant, which falls under MODY type 9. So PAX4 stands for paired box 4 gene. It encodes a transcription factor which involved in beta cell development and also maintaining the beta cells in differentiated form. So it is a rare autosomal dominant inheritance, and several variants have been associated with different types of diabetes like type 1, type 2, and also monogenic diabetes. So in this case, it just helped us to understand why this child is behaving a little atypical of type 1. And it explained us what was the etiology in this child. So last case is 20 years old male, normal BMI, family history of diabetes, and he was hyperglycemia. He was referred to us after a few months of diagnosis, and he was on 3 weeks insulin around 15 units per day. And his C-peptide, both fasting and stimulated, were within normal range, and autoantibodies were negative. And you can think that 15 units for a 20-year-old male is very, very low. So we had suspicion because of the family history of diabetes, small dose of insulin, normal C-peptide, or negative autoantibodies. And we suspected MODY in this subject, and we treated him in glimepiride, a small dose, and within few months we were able to wean off the insulin, and he was completely having a good glycemic range with HbA1c of 6.4. So the MODY screening showed he had a heterozygous mutant variant in ABCC8 mutation gene, which falls under MODY type 12. And usually they are very responsive sulfonylureas, which we shown in this case. So what if clinical features and autoimmune markers are equivocal? So to answer this, the team from Exeter Genetic Department looked at a novel way of discriminating monogenic diabetes and type 1 diabetes. So what they did is they developed something called genetic risk score from 30 common type 1 diabetes associated SNPs as a novel way to discriminate monogenic diabetes from type 1. I'll just put a short abstract here. So if you see, what they say is a score of a type 1D genetic risk score of more than 0.28, which falls under the 50th centile for type 1, is indicative of type 1 with a sensitivity of 50% and specificity of 94%. Similarly, they developed a risk score to differentiate between type 1 and type 2, and here again a score of more than 0.28 was indicative of type 1 with sensitivity of 50% and specificity of 95%, whereas a low score of genetic risk score less than 0.24 was indicative of type 2 with sensitivity of 53% and specificity of 95%. But although it sounds interesting, we need more validation, especially on our local population, and moreover, it has to be cost effective, affordable, and accessible. Maybe in the near future, it might come as a handy tool. So with this, I end my talk. So the key points for my today's talk is diabetes is a diagnostic specialty. Not a single clinical criteria or a single investigation might differentiate all the subjects of diabetes. Sometimes we have to use multifaceted approach. Increased prevalence of overweight and obesity is increasing diagnostic dilemma in our type 1, type 2. Explosion of genetic testing technology and knowledge is helping to reach diagnostic etiology in some of these cases. And genetic diagnosis is more useful guide to our clinical management, as shown in our couple of cases. The same MODY genes which are involved the same genes which are osmotic can also be involved in type 2 in later life. So it is a continuous spectrum of the genetic variation. And achieving a appropriate diagnosis and following an appropriate treatment, we might be able to provide a precision medicine, which means we'll be able to achieve good therapeutic levels at the early on, and which will have a good legacy effect. With this, I end my talk. Thanks for all your attention, and I'm happy to take any questions on this. Bye.